What's up, guys, to another episode of Nursing and Flow. It's your boy C Money RN, special guest Kanan Brown of the ER Forum.
What's up, guys?
Glad to have you with me, man.
Good to be here, man. Good to be here.
So today's episode, we're going to be discussing an ER nurse versus an IMC nurse. Welcome to the episode. So Kanan, first question, man. Tell me a little about yourself and what do you do as an ER nurse exactly?
So like I said, my name's Kanan Brown. I'm an ER nurse here in the Las Vegas Valley. I've been working in the ER almost 2 years now. It'll be 2 years in January. I went to college here, went to Nevada State College, graduated, got a job right into the ER. So I've been there ever since at the same hospital. And basically I assess and manage and treat as a part of a team emergent patients in the emergency department. So we see all different kinds of patients, patients that will eventually go to the ICU, patients that go to IMC, patients go to med-surg, med-tele, the OR, and some people that we discharge. So
awesome, man. So an ER nurse coming out of nursing school.
Yeah.
So I'm sure people always ask you this all the time. How did you get a job coming out of nursing school as a new grad to get as an ER nurse?
Luck.
A lot
of luck, and some things that I've done on my own. So I 100% got this job because I knew somebody and somebody knew me. With that being said, I did do a lot of, I guess, cold walking into different ERs, asking to speak with their director. I actually did that to 3 of the local hospitals here in Vegas. All 3 actually spoke with me. They all had time, 5 minutes to come speak with me.
Yeah.
One of them actually said, listen, you know, I would love to have you, but we actually already have spots filled from people that they knew. They said, I'd keep you in mind, but I'm sure someone's going to pick you up later down the road. I ended up getting the job that I currently work at now, and 2 months later, this director actually emailed me asking me, hey, we have a spot open for you. So if I did not get this ER job, I still would have picked up that ER job 2 months later. So actually doing that was still beneficial because she would not have known who I was unless I went in and talked to her. But got this job because a friend of mine had messaged one of our professors back at Nevada State College, and she knew the CNO from this hospital. And so he got an interview, right? And then interviewing him, he said, hey, listen, I know you had a lot of students that wanted to be in the ER. Give me their numbers or let them know to contact me. Yeah. So he knew I wanted to be in the ER. So he texted me and said, hey, listen, talk to, call his office, let him know that you're interested. He told me to come down and basically just give me, just offer me the job on the spot. So yeah.
That's what's up. So
yeah, very interesting.
Lesson learned, guys. You know, coming out of the gate as a new graduate nurse, most of the time, people are going to tell you, oh, this hospital doesn't hire new grads. This particular unit doesn't hire new grads. You hear that all the time, right?
I hate it.
But despite that, you got to keep grinding. I mean, like what Kanan said, he actually went to the hospitals that he previously had experience at for clinicals in nursing school, and he went to the floor units. He talked to directors. He talked to managers. I can relate to the same thing. During my 3rd semester, how I got my job at IMC was I kind of treated it as like an open interview. I was really nice to everyone on the staff, from the dietary people, from the dietary respiratory therapists, the CNAs, the nursing staff, everybody. They recognized me, and when I applied coming out of nursing school, I was hired more based on merit and reputation because they saw me as Christian, that helpful nurse. During his clinical rotations, and that's how I got my job as an IMC.
It's everything. It's everything. You know,
exactly.
Word of mouth is huge, and I try to stress this a lot to the people that watch me, is that I can get the best grades I can possibly get. I can be the best student. I can be a part of all these clubs, but if I'm not someone who's able to network, if I'm not someone who's a likable person, who's able to communicate with people very well, my chances of getting the jobs that I want are a lot less because as a hiring person, so I'm someone who's definitely seen new grads coming through the ER.
Yeah.
And so now I'm in the position where I could possibly be someone that could be hiring someone in the near future. And so what I want to see is not necessarily how well you did in school, but how likable you are. Do you come into the interview, do you have a smile on your face? Does everyone else speak highly of you? Are you someone that asks a lot of questions and really wants to be here? And so those are the nurses that I would want in my department, not necessarily the smartest person in the class or someone who got the best grades or the best test scores. So yeah.
Exactly.
Yeah, I agree.
Listen to Kane and listen to me. Work hard, present yourself in a professional manner, and that's how you're going to get a job in any department that you want. You don't have to necessarily start in med-surg. You could be in any unit that you want. You just got to work hard for it, right?
I agree.
Awesome. So Kanan, next thing I wanted to talk about is, I'm sure the viewers want to know, what's like the big difference between an ER nurse versus an IMC nurse?
Perfect.
So let's get into it. I'll kind of explain, because I don't think I've explained what an IMC nurse does. Okay. So what an IMC nurse stands for is intermediate care. And how I like to describe it is you have 3 different tiers from after a patient gets triaged, goes to the ER department. You have 3 different units, okay? For an adult, you typically have med-surg, you have intermediate care, and then you have ICU. So ICU is that top critical care unit. Those are the patients that are in really critical shape. Kanan talks a lot about in his videos about the types of patients that he gets through the ER, have to go straight to ICU, like patients that have to get intubated, for instance, patients that get into big accidents, they're in really critical shape, they need certain drips. I can get the same types of drips when it comes to IMC, but the thing about IMC is that we have to keep everything at a fixed rate. So things like amiodarone, dopamine, all those types of medications, we have to have a fixed rate. And once we kind of play with those numbers, that's when they end up going to ICU. But I'm kind of getting off topic here. So the way I like to describe it is I'm taking care of patients that are in critical condition but are stable enough to be kind of considered a med-surg patient, so right in between. And the types of patients that I get to take care of are heart cath patients. I get to take care of patients that had just come off intubation, they just got extubated. Patients that
those are fun.
Yeah, those are definitely fun. Patients with heart conditions, like my particular hospital, we work with a lot of patients who come in for heart caths, cabbage surgeries, and that sorts of things. So different varieties. So if you want to have that variety and that perfect combination of critical care and also bedside especially, IMC is the way to go.
IMC, nice.
What do you think is like the big difference, the biggest takeaway from an ER nurse compared to like a floor nurse? In your opinion?
So I think obviously we have our own policies and procedures,
Right.
so what we're expected to do, and I think that's where you get these clashes between ER nurse, IMC nurses, ICU nurses, IMC nurse, all these clashes, and it's because you're doing what you're trained to do on your department, and I'm doing what I'm trained to do on my department, and those are going to be different depending on what facility you work for. And so there's a lot of clashing between people either trying to give report or trying to downgrade a patient, say to the IMC from ICU, trying to upgrade a patient from IMC to ICU, so things like that. And so with the ER, we have a lot of things that we need to go about in order to get patients to the floor. We have certain time limits that we're under that we need to get patients to a certain floor. I know a lot of the IMC and med-surg patients or floors won't let certain patients go up to the floor if their blood pressure is a certain level, or their heart rate's a certain level, or they're on certain medications, like he says. If they're not on a fixed rate on these drips, they can't go to the IMC, they need to go to ICU. So unless I fix that blood pressure at a fixed rate or keep them sedate, or unless I keep these individuals on a fixed rate on these medications, they cannot go to IMC. And so that's when you start to get these clashes, because when I'm calling the IMC floor to give report and this patient has a muse that's terrible, they're not going to take the patient. Well, I understand that from an IMC point, because they can't take that patient. That's a liability. And at the same time, the ER is going to be complaining because we need to get this patient up, because now we have more patients coming in through triage who we need this bed. And so we're constantly battling with each other back and forth in that situation.
Exactly. So, and guys, in case you don't know what a muse is kind of like a hospital algorithm. So the higher the number, the more critical shape they are. So let's say a patient has a respiratory rate of 30, okay? Their heart rate is in the 160s.
Right.
Their muse score is going to be super elevated. What's the max level of muse, do you think? A 6?
6.
A 6?
I think it's a 6.
So when you get to a 4 and above, that's when you got to stop and ask yourself, do I need to call a rapid response on this patient?
No, and that's the thing. So if he's not paying attention and I'm giving a report to him, I'm not paying attention to the patient's vital signs, and we send this patient up, he's going to do an assessment, assess this patient's muse scores, and within 5 minutes of me getting that patient to that room, we're going to get a rapid to that room, because their muse are a certain level, whether it's their respiratory rate, their O2 sats, their blood pressure, their heart rate, things like that. So we use these muse scores to identify if the patient is appropriate for that given unit.
Right on. All right, so the next part of this video, this is going to be fun. We kind of want to discuss what are some things that we don't like about each other, not as personally, but kind of just like based on our unit. So what are some things that I don't like about ER nurses, and what are some things that Kanan doesn't like about the IMC nurses? Or you can even talk about med-surg nurses in general, because we're kind of like in that bubble area.
Okay.
So perfect.
So you want to start?
I think I'll start.
Go ahead and start.
So Kanan, man, one of the things I don't like about the ER nurses is, why do you got to bring up patients right at the shift change? Like when I'm starting my day at 7 o'clock, when I'm trying to get my report from the poor night shift nurse, why do you got to bring a patient up to me right away, man?
That's a great question. So another misconception, it's not my fault. So he's struggling because he's getting patients at shift change, okay? It sucks for us too, because it's not up to me whether the patient gets a room at that time. So the house supervisor is who gives us these rooms. And so the house supervisor kind of controls the whole hospital throughout the night or throughout the day.
Right.
And so they understand that during shift change, there's going to be more nurses coming on. And so they're going to hold beds at a certain point until their shift change happens, and they're going to deliver beds. Now, if they deliver beds in the ER, I'm on a time limit. And so I got to get this patient up to this floor within a given time period, or I'm going to start getting docked, or I'm going to get in trouble, so to speak. And so it ends up being usually at shift change, which is kind of funny. And they get the bad part of that, the bad end of the stick. So
yeah, so I understand. You know, Kenan, it's not completely your fault, but you know, for me as a floor nurse, it's really annoying though, and I know it's not Kenan's fault, but it's annoying because one, you're trying to get your day started. You don't know much about any of the 4 patients. So
yeah,
for IMC, we get 4-to-1 ratio. You don't know anything about the 4 patients that you're getting when you come onto the shift. So in the middle of your report, it's kind of an inconvenience. So it's like, oh man, I'm getting another one right now. So
no, it's huge. I totally understand that. I feel you with that.
So that's where it's coming from. So nothing against you about that.
Interesting. Okay. So one thing I want to ask IMC nurses, or you know, any of the floor nurses, is why is it necessary to understand if the patient's skin is intact for a 22-year-old healthy patient who has a fractured femur?
Okay, so skin intact, that's an important thing. So the one thing you need to distinguish when patients come in the hospital, you want to make sure that the wounds that they have, any of the injuries that they have sustained, you got to make sure that was not present before they get admitted to the hospital. Mm-hmm. That's why you have to document everything. You take pictures of all these wounds, and you got to make sure, did this happen before they came to the hospital, or did this happen while they came into the hospital, right? Because it's a big liability issue. Let's say a patient comes into the ER, he hits his arm against the railing, and he causes a big bruise, right? Mm-hmm. As an IMC nurse, I have to question Kenan. I got to ask him, hey, Kenan, where did this wound come from? That's why I got to ask if the skin's intact while they come up. I got to make sure that these injuries aren't sustained, during the hospitalization.
Solid reason.
Solid
reason to ask.
Yep.
Another thing that ER nurses do not like about floor nurses when we give them a report is, say we have a patient who is on diltiazem.
Right.
They're on a drip, and because they have AFib RVR, they had AFib RVR, and we're controlling at a fixed rate to go to IMC. Mm-hmm. So you're giving a report on this patient. I'm giving them the cardiac history this patient has and things like that. Everything really important, right, that they came in for, and they're worried about the 3.4 potassium level, and they're asking why wasn't that fixed down in the ER? What's up with that?
Okay, so I know that you're in a rush to get patients on my unit, Kenan, but at the same time, if there's things that could be fixed, such as a low potassium 3/4, don't you think you can get orders to replace the potassium before he comes up to my unit?
I will get yelled at if I try to ask a doctor for that. Hey, his potassium 3.4, can we give like 20 PO? He'll be like, why are you bothering me?
Why are you bothering me? Exactly. So I don't know. So a lot of the things that patients, before they come up to the IMC unit, they can be fixed on the ER. But I guess what I have to realize too as a floor nurse is that they're on a time crunch. They're getting patients constantly, fast and quickly. So it's not that that they don't want to do these small minimal tasks. It's that they gotta be able to move patients quick as possible so they can bring in the more critical patients at their disposal, right?
Right. We got to prioritize the patient. Right. So like for that patient, what was more important at that time was that he needs to be on a cardiac drip. Okay, what was more important was that I was managing the blood pressure and the heart rate. I'm aware that the potassium level was low, so to speak, but again, it's a level of priority that we have to do. And so by the time I'm even thinking about the potassium level, this patient's now stable. I have another patient coming in who's septic, right? He's going through septic shock and his blood pressure's in the tanker. And so by the time I get a room, he's asking about the potassium level, and I'm like, yo, I was not worried about his PO potassium with a 3.4. Like, I just don't.
Yeah, man, I'll fix the potassium. But Kenan, one thing that's inexcusable though is, why do you have to bring up patients that have a poor IV access?
What if this patient's like a heroin user, like a former heroin user? I can't get a line. So this happens a lot. We get hard sticks in the ER, and so I'll end up putting like a 24 in the pinky. You know what I mean? And then they're wondering they have like no access, and so. If it was up to me, I would get a PICC line placed in everybody, but a lot of times patients are on a no PICC line list because they're constantly in the hospital, and so they don't want to put a PICC line in these patients. Or sometimes if I need to put a PICC line or a midline, I need coags. Well, I can't get coags if I can't get blood, I can't get access. And so it ends up getting into this situation where we end up sending them to the IMC floor with terrible access. I mean, like a lousy 24, 22 in some weird area where he can't really work with it. I mean, he can't give any really important medications through there because they're it's an issue. And so I feel that. I feel the struggle.
I guess that's kind of the big difference between an ER nurse and a floor nurse. So the floor nurse, once you get onto the floor, you have an admitting doctor that's going to take care of your overall care, what meds I'm going to prescribe you, whether or not I'm going to continue these home meds, yes. What type of care, what kind of test do I want to do from this, that, and that. So by the time they get onto my unit, the admitting doctor is already established and a lot of orders gets placed. And so the only reason why I'm kind of complaining about the whole IV access is that sometimes a doctor would put in an order like, oh, start a heparin drip, oh, start like these IV fluids, right? Yeah. And then when the patient comes up to my unit and I don't have an IV access, and I'm like, oh crap, what am I gonna do? Because I'm already enough. I got other patients to take care of. It takes a lot of time.
Oh wait, people are going to your floor with no IV access?
Sometimes, yeah.
Oh yeah, no, I won't do that. I won't do that. I'm not gonna send anyone to your floor with no IV
Please
access.
don't, man. Please
Everybody
don't.
gets a line, no matter what. Without a doubt. That's crazy.
Yeah, but that doesn't apply. That's only in some instances. Most of the time, they are going to have an IV access, but that's why when you're getting a report from an ER nurse right on the phone, you got to make sure, how's the IV access? Is it working?
That's a huge question.
Is the skin intact?
Oh my God, the skin. Back to the skin.
So yeah, man, but that's pretty much, I guess, like the idea, a difference between an ER nurse and an IMC nurse, and these are the kind of the points that we wanted to make in this video.
I mean, it's just like I said, it just depends on your floor. He's doing what his job is, and I'm doing what my job is, and naturally there are going to be differences, and so they're going to be bickering over the phone or during a report or and stuff like that. And so every floor is different that you're going to work on. There is no universal way to treat patients.
Right.
Every single floor has their own rules and policies and procedures that you have to follow, and so naturally that's going to cause some conflict.
Exactly. Yeah. And don't take it the wrong way. Just because me and Kanan are kind of going back and forth to discuss, what are some things that we don't like about each other's units, doesn't necessarily mean we hate them. It just means that, there's some things that can be fixed. And, as the future of healthcare professionals, it is up to us to kind of make these adjustments.
We got to fix them.
We got to fix them. Because we are the future.
I appreciate you for having me on the episode, guys.
Awesome. So, thank you guys for watching this episode of Nursing and Flow. Hope you guys enjoy. If you haven't yet, please subscribe to this channel. Hit that like button. Leave a comment below. Also, if you haven't checked out Kanan's channel, the ER Horror Forum, I'll put the link below. Try to subscribe to his channel as well.
Yeah.
Thank you guys for watching. Take care, guys.
Cool, man. Easy. How long was this one? 17?
Yeah, not the longest video, man.
Really?
Yeah. Okay, thumbnail.
Bustling through the bears that try to contain me. Moving on up, making moves of money endlessly. How you think I got this name? C Money, it's my specialty.